Today, we're going to put on our detective hats and solve a really fascinating medical mystery. And guess what? Our only real piece of evidence is a patient's vision. We're going to follow the clues, starting from the eye, tracing them all the way deep into the brain to figure out exactly where a problem is hiding. All right, let's get right into it. So our case kicks off with a 57-year-old man and this one seemingly simple complaint. He just keeps bumping into things on his left. Now, that might sound like a small, almost clumsy kind of problem, but in medicine, little details like this, they are often the most important clues. And that's really the big question here, isn't it? How can we take this one symptom, this one observation, and use what we know about the brain's incredible wiring to crack the case? This is exactly how clinicians think, day in and day out. And hey, by the end of this, you'll be able to think that way too. So let's do it. Okay, let's officially open the case file. The mystery, a patient's puzzling vision. Our job is simple. Follow the evidence, rule out the suspects, and zero in on exactly what's going on. All right, here's the full rundown. We have a 57-year-old man. He's got these throbbing headaches. He's seeing some zigzagging lines. But check this out. This is the kicker. He has vision loss in the exact same spot in both of his eyes, the lower left quadrant. Now that, my friends, is not a coincidence. That is a massive clue that immediately tells us where the problem isn't. So to really understand these clues, we first have to understand this system itself. Let's trace the journey of a visual signal, right from the moment light first enters the eye. Okay, so first things first, you gotta understand this one fundamental rule of how we see. The lens in your eye, it acts just like a camera lens. It flips the entire world upside down and backward right onto your retina. So everything in the upper part of your vision lands on your lower retina, and everything you see on the left lands on your right retina. This whole inversion thing is absolutely crucial for our investigation. You have to remember this. So once that light hits the retina, these two types of cells get to work: rods and cones. They're the ones that actually convert the light into an electrical signal the brain can understand. You know, rods are for your low light, kind of black and white vision, while cones handle all the bright light, the fine details, and of course, color. They are step one in this amazing biological circuit. So, this brings us to our first major deduction. Could the problem just be in the eye itself? Or maybe the optic nerve that's connected to it? Well, here's the rule. A problem in the eye or in the optic nerve before it gets to the brain's big interchanges is only going to affect the vision in that one eye. But our guy's vision loss is identical in both eyes. What does that tell us? Boom, we can officially rule out the eyes. The culprit has to be hiding deeper in the brain, somewhere after the signals from both eyes have started to mingle. So our investigation now leads us past the optic nerves to the first major junction box in the brain, the optic chiasm. And trust me, this is where the wiring gets really, really clever. Seriously, think of the optic chiasm as this super important highway interchange for all your visual information. It's not a complete merger, though. It's a partial crossover. The nerve fibers from the inner half of each retina, that's the half closer to your nose, they cross over to the opposite side of the brain. But the fibers from the outer half, they stay on the same side. This whole setup is designed to do one thing brilliantly: make sure everything you see in your left visual field is processed by your right brain and everything on the right is processed by your left. And this table right here, this is your diagnostic cheat sheet. It's awesome. It shows you just how powerful that wiring is for figuring things out. You see, if you cut an optic nerve, it only affects one eye. A lesion right in the middle of that chiasm interchange, that creates tunnel vision. But a lesion after the chiasm, in the optic tract or radiations, that creates what we call a homonymous defect, the same-sided loss in both eyes. Sound familiar? That's our guy. So let's use our cheat sheet. Our patient's got that same-sided vision loss. Does that fit with a lesion right in the chiasm itself? Nope, not at all. This tells us we need to look even further down the pathway. We've just narrowed the search area down in a big way. Okay, so we know our problem is somewhere past that big interchange. This is the part of the journey where the visual information, now all neatly sorted into left and right fields, travels back through the brain to get processed. After a quick pit stop at a relay station in the thalamus, it's called the lateral geniculate nucleus, or LGN, the signals fan out into what we call the optic radiations. And again, the brain's wiring is so specific here.
The fibers that are carrying info from your upper visual field, they take a low road, looping down into the temporal lobe in a path called Meyer's loop. And the fibers from your lower visual field, they take the high road, straight through the parietal lobe. And this specific wiring gives us one of the absolute best, most memorable mnemonics in all of neurology. You're going to love this. A lesion in the temporal lobe damages that lower path, right? So it causes a loss of the upper quadrant of vision. We call that a pie-in-the-sky defect. A lesion in the parietal lobe damages the upper path, causing a loss of the lower quadrant. That's a pie-on-the-floor defect. Easy, right?
Okay, now let's apply this to our patient. What does he have? Vision loss in his left lower quadrant. That's a pie on the floor, an inferior quadrant tantalopia. This tells us two huge things. Number one, the lesion has to be in the superior radiations. And number two, remember how vision crosses over? A left field defect means the problem is in the right hemisphere of the brain. We've just narrowed our search down to a very specific spot, the right superior optic radiations, probably in the right parietal lobe. We are getting so close to solving this. We are at the finish line, folks. The signals have traveled from the eye, they've crossed at the chiasm, fanned out through the radiations, and now they're arriving at their final destination. And that final stop is the primary visual cortex, tucked way, way back in the brain in the occipital lobe. This is the place where all that raw data from the eyes is finally put together into the coherent picture of the world that you see. And just like every other part of this pathway, it is organized with incredible precision. And this right here is the final, crucial step of our deduction. The cortex itself has a map, and the information from those superior radiations, our pie on the floor data, it lands right on the upper bank of a deep groove called the calcarine fissure. So our patient's left inferior defect points us with, pinpoint accuracy to a lesion on the upper bank of the calcarine fissure in the right occipital lobe. Boom, case solved. So let's just quickly recap the logic we used. We started with the symptoms, then we characterized the visual field defect, a left inferior homonoma squadrantanopia, if you want to get technical. Then we mapped that defect to the pathway, ruling out the eye, the optic nerve, the chiasm, and finally, using those awesome mnemonics, we localized the lesion. So by literally just following the brain's own wiring diagram, we've solved the mystery of where the problem is. But in medicine, that's really just the beginning. The next and maybe even more critical question is, what is that lesion? Is it a stroke, a tumor, an infection? And that's where the next phase of the investigation begins.